Hey, how's it going? Thanks for joining. Hey, what's up? So for those of you guys who don't know, I'm an orthopedic surgeon. I work in Washington, D.C. and Maryland. Thank you for joining the live stream. Just going to be on here answering a couple questions and anything that you guys may be interested in. So I do a lot of hip and knee replacement operations. I do a lot of what's called outpatient surgery, meaning it's same-day surgery. Hey, how's it going from upstate New York? So a lot of that's been a big change in orthopedic surgery, kind of in the last little while, is doing outpatient surgery. I work at a surgery center as well. OR nurse, nice. Shout out to the OR nurses. Couldn't do my job without them, so always appreciate a good nurse in the OR. Hello from Ann Arbor. Nice, Michigan. So I'm guessing you're not an Ohio State fan. I went to LSU though, so go Tigers. Why does my reconstructed knee ACL pop and feel weak? It's been 3 years. Well, it depends how your ACL was reconstructed. So ACLs can be reconstructed in a couple different ways. You can use what's called bone patella bone, which has the highest and best result of incorporation. The next thing, sometimes you can use a quad tendon, that's a newer type thing, or you can use a hamstring tendon. Those are called autografts, meaning they're taken from your body. And if they're taken from your body, they have a better chance of incorporating. So the gold standard for an ACL reconstruction is a bone patella bone graft. The next step is an allograft. So you had hamstring. Hamstring, I would say, has the second lowest revision rate. And sometimes over time, the ACL can stretch out, which can lead to meniscal damage, can lead to cartilage damage in the knee. So it's always good to get it checked out, and you can get a new x-ray. If it's really bad and not getting better, you can get an MRI to see if there's arthritis. There's things we can do like injections. It depends at your age. If you're very young, then we may do what's called a revision ACL reconstruction. But those are all things that could happen and be reasons for that. Just bring that over a little bit. Okay. To do a complete knee replacement, 30 more pounds, we like to get people at a BMI of 30, a BMI of 40, and that's not a hard cutoff for me. I will operate on people who are BMI more than 40. I have done hip replacements on patients as big as 350 pounds, so it really depends on how damaged your hip is and what your quality of life is and your age too. Like obviously we try and get you to lose weight, but that doesn't always mean you can. And if quality of life is really bad, then it may be worthwhile to do the operation. Now for every pound you lose, it takes about for every 1 pound, it takes about 4 pounds of pressure off a joint. So if you lose 20 pounds, that's like 80 pounds off your joint, which is huge, which can be really helpful. That's one of the treatments for actually arthritis, is losing a little bit of weight. Sorry to hear that, Bullfrog. How long does the hip replacement take to heal? Hip replacements take about usually 8 weeks for most of the recovery, but you'll get stronger even 6, 9, 10 a year after the operation. Have you ever taken out kneecaps? So what you're talking about is called a patellectomy. It was an older procedure which we used to take out the entire kneecap. Since I've been in practice, that is not something you do anymore unless there's a reason. So I've treated people who have had patellectomies, meaning they've had all their kneecaps taken out. I've also, there's something called where the kneecap doesn't actually form, so you're actually not born with a kneecap. And I've treated patients with replacements with that as well. So, the procedures back in the day weren't as good. It's not something we're doing as much. We have something called a patellofemoral replacement where we can replace that joint instead of take it out. But everyone has different reasons if they had their kneecap taken out. For doing anterior hip, I do anterior hip replacements. If it's a big revision surgery, I may do a posterior, but most of the time I'm doing anterior hip replacements. I feel like the recovery is a little quicker. Patients are getting up and moving. My same-day surgeries do well with anterior hip replacement. So It's a minimally invasive. It's called a muscle sparing surgery, meaning the surgery is performed between the muscles, and so I love that. Leg length discrepancy post hip replacement for dysplasia. So this is a great question. There's two types of leg length discrepancies. There's a perceived leg length discrepancy, and then there's a real, or we call it apparent leg length discrepancy. So one of them is if you actually measure the lengths of the legs, it could be the same, but you could feel like your leg lengths are different. So if you've lived your whole life with a short hip, meaning you have dysplasia, your hip is short, it's high in the socket, there's different levels of it, and then you get a operation to replace that hip and bring it out to length, you may perceive that your leg lengths are longer because your body has been compensating for it your whole life. So if that's the case, I would measure you clinically, and if it's the same, I would say try and go a year or so without putting a shoe lift in. Now, if you're a year or more out and you feel like you still have a discrepancy after surgery, then I would put a lift in. But a lot of the times your body and your pelvis can compensate, and once you're even, you just need some adjusting to do. Hey, how's it going? Let me see if I can take a look at these comments. Yeah, if you guys have any questions, just drop them in the chat. I'll try and get to them as quick as possible. Suprapatellar or infrapatellar approach for tibial nails. It depends on the patients and the anatomy. You know, if it's a really tight space between the kneecap and the femur, then you can't always get a suprapatellar nail in. You know, most of the time I do a suprapatellar for a trauma. So right now I do mostly either my trauma cases, like my tibia fractures. Those are things that come on when I take call. So I'm doing more elective hip and knee replacements, but I will do tibial nails for trauma. Why won't most surgeons treat postoperative pain adequately? I don't know if it's other specialties that are outside of orthopedics. I mean, for me, I give my patients a pain regimen from, I would say an average one would be like Tylenol combined with Celebrex combined with Tramadol, which is a narcotic, and then oxycodone for breakthrough pain. So I do give narcotics. All patients have access to it after surgery. That doesn't mean that all patients are actually using narcotics after surgery. I have many patients who just get by with Tylenol, Celebrex, and ice, and they do just fine. But they have not access to narcotics. Do I ever get queasy during surgery? No. You learn to, it's just like pouring a cup of coffee or drinking some water or making some food. You do the same thing over and over again, and you get used to it. So I have seen people pass out. Now there have been like students who have passed out, or if you lock your legs for too long or really dehydrated, that can happen, but not queasy anymore. What made me want to do orthopedics? It's really an amazing feeling when someone comes to you that can't walk and you fix them. You give them their ability to walk back. It's giving them their life back. So that's a huge thing. What's the craziest trauma I've seen? I've seen so many different traumas. You get pretty desensitized to these things. I actually just posted a video up on my longest surgery ever. I put it on TikTok and YouTube, and it details probably one of the craziest trauma experiences. It was a really long surgery, so the title is Longest Surgery Ever for me, and that's posted to both my TikTok and my YouTube, so I would check that one out that I just put up. But that one, it took me about 16 hours for that operation, so it was a long one. Let's see, before doing knee replacements, do you make sure the legs are equal in length? So that's a great question. You know, that's part of the physical exam. Before you operate on everyone, you want to know everything about that joint, everything about that patient. The thing is, we actually I don't personally adjust the leg length during a knee replacement procedure. You can do that during a hip replacement procedure, but the knee, not so much. The thing with the knee is I'm taking like 10 millimeters of bone and I'm replacing 10 millimeters of bone. So I don't want to lengthen the leg when I do a knee replacement. I want it balanced, and that's what I'm going for. So Yes, I look at leg length, but even if it's short, that's how the patient's been living. I'm not adjusting leg length with a knee replacement. Some of the videos gross you out. Yeah. I guess especially some of the, probably more of the ones on YouTube, because you can get a little bit away with a little bit more there. But you know, I'm sorry if you came across one of those. Sorry you had a bad experience there. How do we know that you are what you say? So my credentials are online. You can look me up, Dr. Matthew Harb. You can go to Johns Hopkins website. I'm on Johns Hopkins. I'm affiliated with Sibley Hospital. All my links in my bio. You can read reviews about me online. So if you know, you can match it up. This doesn't mean anything, but you can match up the face. So it all you know, if you want to make an appointment or telemedicine, I have links to that too if you really are interested. So sorry, the chat's flying through, but my mom had a TKA, which is a TKR, total knee replacement, and they put in a spacer. How long are antibiotics required? So this is how we take care of an infection. Infections risk can be anywhere from 0.5 to 1% after an operation, depending on what facility you're at and patient risk factors. And if you get an infection in your joint, what we do, if you have a prosthetic in, we take the prosthetic out and we put in what's called a spacer. The spacer is cement, and it's loaded with antibiotics that help to kill the bacteria in the knee. We debride all the bone, meaning we take all the dead bone and infected bone and take it all out. We take everything out. We put these spacers in. I'll do what's called antibiotic beads, meaning I'll put these beads that dissolve antibiotics. I'll give a PICC line, which is a line that you go home with and you get IV antibiotics at home. And I put my patients on that for 6 to 8 weeks. Then I give them what's called an antibiotic holiday, where I put them off all antibiotics and then check their labs again to make sure they're not continuously infected. Sometimes they'll stick a needle in their knee, drain some fluid, and test it for an infection. And if it's still infected, I'll wash it out again. If it's not infected, I'll take them back to the OR and I will reimplant them with what's called a revision knee replacement. All right, PT, yeah, PT see ortho all the time. You know, I have therapists I work with. We have therapy, physical therapy in my practice. Therapists are great, and you're going to be working with ortho all the time. You look young. Thank you. I appreciate it. Heater ice. So, you know, there's been this, I've posted this thing, you know, ice does not delay healing. The studies that were done and these things that were published on delayed healing with ice, that is not, you know, there is no difference in overall, you know, in a delayed healing reaction with ice. So acute injuries with inflammation, I treat with ice. All of my post-op joint replacement patients get what's called an ice machine. And I see the ones who get the ice machine and I see the ones who don't. And my patients who get ice machines after their new replacements, they do better. They have a quicker recovery. So I believe in ice for acute inflammation. I believe in heat for long-term muscle injuries, and that works pretty well. What types of shoes for walking and hiking? Walking, Hoka and Asics are really good brands. Hiking, just a nice supportive boot. A lot of the boots go up above the ankle. They're strong and good. I would say if you're having a big pack on your back or something like that, you can use hiking poles. I carry my kid around on my back, so I use hiking poles and nice boots. I don't want to have an injury. So definitely protect yourself if you're hiking. Do you do shoulder replacements? My partners in my practice do shoulder. I really stick to hip and knee replacements. What shoes do I wear in the operating room? All right, so let's do this. If you were a surgeon, or if you are a surgeon or doctor, what shoes would you want to operate in? Let me know in the comments, and then I'll tell you what I operate in. You know, so there's a bunch of different options. People operate in cowboy boots. People operate in sneakers. People operate in Dansko shoes. We got a couple answers for Crocs. Dansko. I've never tried the Dansko. I don't, you know, personally, I don't think they don't fit my style. So I've never. But people love them. Hoka. Yeah, Hoka's a great brand. I wear Crocs. The reason for that is they get really good traction. I don't wear the ones with holes in it. I wear the ones that are closed. So, and they wash off with, they wash off pretty easy. You use a little hydrogen peroxide on them, you get any blood on them, it just comes right off. So Crocs are great, they're comfortable. And a lot of the times, like when you're sitting back, like using a mallet to hit an implant in, right, you don't want to slip. Like I've seen people slip in the operating room during an operation, and it is not good. So you want to shoe with traction, and Crocs get good traction. All right. Reversal of what? Can't find a doc to do a reversal. Reversal surgery. I don't know. I don't know exactly what that means. Once you have a joint replacement, you can't reverse it. Shoulder replacement. They can switch you to what's called a reverse total shoulder from a total shoulder. And, I'm in the Maryland area. There's some specialists here. Hey, what's up, Corey? I put in some insignia stems. Worked pretty well. Hope you're doing well, buddy. Corey's another orthopedic surgeon on here. He's in the chat. He's great. You should check him out if you haven't seen his channel. He does a bunch of great orthopedic stuff as well. Hip replacement popping all the time. There's a couple different things that can pop. You can have internal or external popping after a hip replacement. So it could be, depending on how much offset you got, it could be the IT band popping. You would feel that on the side of your hip. If you feel like it's popping in the groin, that could be your iliopsoas muscle. It would be helpful to see x-rays, look at the position of components, see if something is maybe too big or malpositioned. And that could sometimes relieve the popping. Sometimes a cortisone injection can relieve popping. The goal is to hopefully get rid of that by a year or two after surgery. I've worked in orthopedics for over 19 years, engineering. That's great. We need engineers. All of our stuff is engineering. How do you prevent a bone from splitting when drilling? So, orthopedics is very much like carpentry and building a house. So if you just try and put a screw into a piece of wood, that wood, depending on the size of the screw, that wood will just splinter and split all the way up. So there's a couple different things that you can do. You can first drill a hole before that, which is usually 1 millimeter smaller than the screw. Or you could do something called tapping the hole, which opens it up a little bit wider. And those are things that when you put the screw in, it's not going to splinter the wood or splinter the bone. So our drills we do have self-tapping screws, but even those will still drill for. The worst thing, you don't want to put a screw in a small bone and have it explode. The self-tapping screws work really well in older patients and osteoporotic patients who may have really, really poor bone. But we do have those. The self-tapping basically is the design of the tip of the screw so that it taps and pulls out bone as you're putting it in. So those work well, but it's basically the same as carpentry. I've never taken like a carpentry class. It would probably be helpful, but it's like a lot of the same techniques that we use in orthopedics, like things called lag screws and different drilling techniques and things like that. I use Nsef for my patients. And then post-operatively, if they need antibiotics, I'll sometimes use what's called cefadroxil, which is an oral antibiotic. There's good literature. It's a newer antibiotic to support it for post-operative for preventing infection. What happens with airport security with a hip replacement? So it depends what the detector's set at. If you go through, you just tell the guy, security guard, I have metal in me. I give all my patients a joint replacement card, which means they get that, they show it to the person. They'll usually either put you through the body scanner or wand you. It's not a big deal. A lot of patients have metal in them. A lot of patients go through metal detectors and still fly. So yeah, show them your card. I give everyone a joint replacement card so they have that, but you just can say you have metal in your body and it's not a big deal. Thanks for joining. I really appreciate you guys supporting the live, supporting my channel. This has been a great opportunity to educate you. And, I really enjoy this. What's my favorite tool to use? So instruments, it depends what I'm doing. We have something called a ball spike pusher. If I'm doing trauma, I just really love that. You can push bones wherever you want to. I like the minimally invasive hip replacements. So there's different things we use for that. I use an instrument called a cob a lot. Yes, you can get an MRI. So MRIs, if you do it with a hip replacement, it will because MRI looks at the magnetic field, and we have certain things called metal subtraction MRIs, and that'll subtract out the metal so you can see more things if you have a hip or knee replacement in. What do you do for compression fracture? You go and you check and make sure you don't have osteopenia. You start vitamin D and calcium. There's no surgery, usually for compression fractures, that I would recommend. Get your bone density up. In some places, they'll do what's called a kyphoplasty. That's falling out of favor, where they put some cement in there. Really just let it heal, let it go. You'll heal up. No precautions. For orthopedic implants that we use, if we're doing an MRI, then it's fixed to bone. The implant's not going to go anywhere. So no precautions with any of the orthopedic implants that I put in for MRI. Yeah, thanks for catching me live. I try to do this every so often. Plasma enriched cortisone stem cells. Yeah, those have been around for a while. Those are options you can inject into your knees, into your joints. Was it hard to get into med school and residency? Yes, orthopedics is one of the most competitive specialties. I was at the top of my class in med school. We take some exam called the step exams. Those have changed, but you want to score at the top. I think I was in the top 1% for those scores, and you need that because you need that just to be competitive with everyone else who's trying to get into orthopedics. You need good letters of recommendation. Some people are taking a year off in med school to get research and improve their applications. And so, the more time that goes on, the more people are going to want to do orthopedics because it's a great specialty. It is for me, there's things called lifestyle specialty, but orthopedics is a great lifestyle specialty for me. My trauma crawl is minimal. I'm in a private practice, meaning I make my own hours, and I get to do things kind of as I want. Thanks for this cool hat. And so it's competitive. People want to do orthopedics. It's also one of the highest paying specialties, and that doesn't hurt either. So people want to be orthopedic surgeons. Work hard, do research, find some good mentors. I love doing hip and knee replacement surgeries. Those are my favorite type of operations. Patients have good outcomes after, and most of the time. And I love it when you give a patient a good outcome. Had a knee replacement surgery, and now I wobble side to side. Is this my hip? Hip issues and back issues can cause wobbling. Total joints, we use Synthes. So DePuy combined with Synthes. So DePuy has Sigma knee or Attune knee. So yeah, I don't think Synthes itself ever made a knee, but they are combined with DePuy, who makes a knee. I have used their knee before. I don't use their knee right now. Do you ever gag during surgery? No. You get rid of all that. When you're in med school, you are exposed to some of the worst smells ever. PFC Sigma is an old implant. It has stood the test of time. It is, for what it is, it's not a newer generation implant, but people did well with it. Their Attune implant had some issues, but I'm located in Maryland and Washington, D.C. I have a lot of info in my bio. There's a link there. I do telemedicine appointments as well. I've had some people fly for surgery. Do you have a PA that operates with you? Yes, I have a PA. Her name is Kelly. She is great. She sees patients in clinic. She helps me during the operation with retraction. She helps me close at the end of the operation. Kelly has been in practice as a physician assistant for about 10 years or so, and she's great. It just makes the patient experience that much better by having more people on board. How long can an intramedullary nail last? Hopefully an intramedullary nail lasts your lifetime. Usually we don't take them out that often. I mean, I've taken them out before, but it's rare. What's the difference between neuro and spine surgery? Neurosurgery operates on the brain, and orthospine only operates on the spine. So neurosurgery does brain and spine. Boston area. Brigham's, I think, Brigham's is a good place. There's a couple good places up in Boston. What is your haircut? I need a haircut. My hair's long right now. I like it short where I don't have to manage it. Have I ever had a surgery go bad? Surgery has inherent risks, right? And as a surgeon, part of your goal is to be prepared for anything that can happen at any time. You do not go into an operation without having plan A, B, C, D, and E. And most of the time, you only have to use plan A, and that's great. That's what we want. We don't want anything to go wrong. We don't want a fracture to happen in the operating room. We don't want to have a tendon that you have to put back. If you know what the complications are that exist, you minimize the risks of those happening. So complications are very low, but they say, one of the sayings, if you don't want, there's an inherent complication risk. If you don't want to have a complication, don't do any operation. So it's part of surgery. Nothing's gone wrong that I can't fix. I can fix anything that comes up. I'm prepared to fix all those things. It's very, very rare. Do doctors get money not to give pain medication? No, we do not get money not to give pain medication. I give pain medication. I don't know any orthopedic surgeons who don't. Can an IM nail? An IM nail is a rod that's put in your bone to stabilize your bone after you have a fracture. Can it cause arthritis? So if your tibia broke and you put a tibia nail in through the knee, or you had a knee injury, yes, you can develop arthritis. Anytime you have any trauma to a joint, that can develop arthritis, or you can just get it from normal wear and tear. Favorite NSAID? In my post-op patients, I use Celebrex a lot. I'll sometimes switch to meloxicam for a longer acting effect, and then I'll use naproxen 500 milligrams. Those are kind of my main NSAIDs. There's other ones. There's Duexis, but instead of using that, I'll sometimes combine an NSAID and just give them pantoprazole, which is a stomach protectant with it, which usually works pretty good. What's the fastest way to become any kind of doctor? Family medicine, so college, get into med school. Med school's 4 years, and then do a residency. Family medicine residency is 3 years. If you're going to be operating in a very rural setting, then you can do that and get a job. Most of the time you need to specialize further to get a job somewhere. ACL recovery, usually starting to do running activities at about 3 months, more sport specific at 6 months, return to sport at 9 months to a year after surgery. So big recovery. You see these NFL players get an ACL tear. They're usually take a season off and come back like Joe Burrow. I haven't had a bone graft from my hip to my wrist. The wrist hasn't been the same since the break. That's a lot. I'm sure it's funny when people have wrist fractures and they need a bone graft from their pelvis actually usually hurts more. So I'm sorry that's happening to you. Hopefully you had a union. I'm curious why they did a bone graft so quickly for you. Yes, orthopedics is incredibly competitive. It's very difficult to get into. You have to study, you have to have research, you have to have good mentors, good letters of recommendation. It is one of the most competitive to get into. Total reverse shoulders are not becoming only for the elderly. There's some good literature to support that reverse total shoulders can do pretty well, and almost sometimes maybe even be better than a total shoulder. So there's a shift that's happening from total shoulders to reverse total shoulders, and that is happening. I have a bone spur on the back of my knee. So bone spurs usually are a sign of something. If you have a bone spur somewhere, it usually means that something is inflamed. Your body's trying to make your joint stiff. It is not always the cause of pain or dysfunction, but it is a sign that something's going wrong. Yeah, I mean, if you break a bone, depending on how you broke it, it can be difficult to run after if you have a tibial nail. It can be. It's tough. It depends how bad your break was. The screws don't always stick out of the bone. Like if you see it on X-ray, maybe they're like a millimeter or two. That's normal. They shouldn't be poking out of the skin. What can be done for mallet finger? Mallet finger is a finger that's stuck like this. And we usually splint it for about 6 to 8 weeks. It depends on how the mallet happened. If it's a bony mallet, meaning it's because of a fracture, sometimes we'll fix that. But you splint it straight and then you can usually get it back. Is it true you need to bench press your step score and need to exceed 500 to match in ortho? Let's see, I got a high step score and I could bench more than my step score at the time. I don't know if I can bench more than my step score now. That was a lot, and I was a lot younger back then, but it's a good start, I guess. Yeah, so the joke is that orthopedic surgeons are strong and big, and unfortunately, we're trying to change it, but it's mostly a male-dominated specialty. More and more women are in med school than men right now, and more women are becoming orthopedic surgeons, but it's something we're working on and trying to get more women into the field of orthopedics. What med school did you go to? How's your GPA MCAT? The MCAT's graded differently now, so it was a 36 around the time. I think I had a 3.9 GPA, and it was a 4.0 in science. I went to LSU. Are you ever gonna meet big? I don't know. I'm using these platforms to grow and teach you guys and provide medical education, and I enjoy doing that. If the channel grows, it grows. If it doesn't, it doesn't. I help people along the way. I have people who come see me in the office, get telemedicine visits, and that's enough for me. Go Tigers! Hey, what's up, buddy? If I could go back and give myself advice before MS1 started, I don't know. I don't have very many regrets. I would say, I think the biggest advice is don't study before MS1 year. Med school is going to be tough enough. Don't do anything. Enjoy your summer. I probably wish I would have taken a long international trip before I started med school. I'd say that's probably my best recommendation. If you're about to start med school, don't study. Don't look at any books. Go on an international trip to somewhere cool and enjoy yourself until you start. And then when you start, hunker down, hit the books, study. It's a long ride, and you'll need a lot of time to do that. Any tips to overcome Trendelenburg gait after THR revision? No, that's hard. The abductor muscles are weak, so it could be due to the muscle itself. It could be due to the nerve. You just have to work on abductor strengthening. So the more you strengthen your abductors, the better that Trendelenburg gait will improve. So that's what I would recommend, to build those abductors. What's the reason for a gluteus medius tear? There could be a lot of reasons. Usually it's trauma or overuse. Let me see how I can pull these. If you had a failed total knee replacement, then revision's the best next option. We'll do a revision for a failed total knee. So it depends why it failed. Was it an infection? Did it come loose? Those are all things that can happen. Thoughts on Prolia? Will I have problems later? Prolia is a drug that we use for osteoporosis. Usually I don't prescribe this for people. Usually I send them over to the endocrinologist or family med doctor to start them on Prolia. It works. It builds up your bone density. So if you're at risk and your frac score is high and you're at risk for fracture, then Prolia can be helpful. Any side effects with knee replacement surgery? Well, you want to get your knee as strong as possible, get as much motion as possible. I don't have restrictions on any of my patients who are on who get knee replacements. Some of them go back to tennis, swimming, biking, and they're athletic after. So nothing to avoid after knee replacement surgery. You may have like tennis elbow or a biceps syndrome. MRI be fine on biceps. So it depends what the diagnosis is. Sometimes they can do a cortisone injection where you're having the pain. How long is the rehab from an anterior hip replacement? Usually I have patients in rehab for about physical therapy for about 8 weeks. I do have patients who are jogging or running after their surgery. So 8 weeks, you're about 80-90% recovered. Is it possible to reattach a failed muscle 2 years after surgery? Could be. If it's a rotator cuff, the answer would be yes. Nerve damage after knee replacement. It depends what nerve got injured. I would say there are some skin nerves where you could have some numbness, but if you have, bigger nerve damage, that could be an issue. Do you have like a foot drop or something like that? A lot of the time, hip can cause knee pain. So we call that referred pain from the hip, and it's good to get your hips checked out. Is your job stressful? I wouldn't say it's stressful. I enjoy doing what I do. I enjoy helping people with their issues. So, time it can be stressful because the work just piles up and there's a lot of people you're taking care of. So that part can be a little stressful, but most of the time it's really not. When you're on call and you have a lot of surgeries piling up or a lot of traumas that are coming in, that can be a little stressful, but it's normal. You're used to it. Thanks. I appreciate that, Alex. Yeah. I enjoy, talking to people. I think these apps have been great for patient education and teaching people things, and it's a really good way to connect with patients. So I've enjoyed it, and I think people have really enjoyed it as well. Is swimming beneficial for scoliosis? So scoliosis is a curve in your back. It means it's a curve more than 10 degrees. If it's more than 40, that usually requires surgery. If it's somewhere in between, you can do bracing for it. If it's once you hit puberty and your growth plate's closed, the curve doesn't really progress as much anymore. But swimming, elliptical are great, biking's great. And so those are all good activities. I definitely recommend it. What orthopedic implants do I use? The big ones over here are Stryker, Zimmer, Donjoy, Smith & Nephew, and DePuy. And I will use a variety of those depending on my patient's needs. That's awesome. Almost back to 100. Are you back in a race car yet? I know that was your goal. So the success rate on a TKR after having no patella is pretty high, actually. So I've done it before, and you use a specialized implant where it doesn't slide forward, but you can have really good results. If you had patella agenesis or you had a patellectomy, it can still be a very good surgery. I've definitely done that before. How do you manage work-life balance? So it depends on the job you take. For me, I am in a private practice, so I make my own hours. I can minimize or maximize the amount of call I take. I do a lot of what's called outpatient joint, so I'm not in the hospital all the time. And so my work-life balance is pretty good. I don't feel burnt out. Now physician reimbursement is continuing to decrease. The hospitals are having a lot of issues with staffing and supplies, and so that part is hard in healthcare. But outpatient is good for lifestyle. I guess the guy there were 2 orthopedic surgeons, I think, that got shot in the Tulsa, that medical center shooting. which is not good, but oh, my heart goes out to them. Can you replace a knee? Yes, I do. Mostly hip and knee replacements. That's my specialty. I do orthopedic trauma as well, but I definitely do those procedures. Rotation plasty? Yeah, I have a video on rotation plasty. It is a great procedure. I know it seems odd that you're taking the ankle, flipping it around and making it into a knee, but actually, when the ankle is flipped around, it is a phenomenal knee joint. And the patients who have rotation plasty are much better off than having an above knee amputation. They are 100 times better. They can live a functional life. They can get up and move. The energy requirements for having an above knee amputation versus having a Van Ness rotationoplasty is massive. So if it was me and I had a tumor in my knee, I would get a rotation plasty, 100%. No problem. Ask any questions you want. ACL meniscus surgery, 2 blood clots. I put my patients on blood thinner after their knee replacements or joint replacements. It's aspirin, baby aspirin, twice a day for about 6 weeks. That usually does a pretty good job at preventing blood clots. I also get my patients up, walk them right away, work with PT, compression stockings, all of that helps with avoiding blood clots and moving blood. How can we prevent knee replacement surgeries? That's a great question. If you find an answer to that, then you will change medicine forever. Arthritis, first way to figure out how to prevent knee replacements is there's a couple different factors that cause arthritis and damage, which is responsible for a knee replacement. The first one are family history, just natural wear and tear over time. Then you can have trauma, you can have autoimmune diseases, which you can't really affect. You can have, if you're very, very overweight, that can put a lot of stress on the joint. That can contribute. It's not the whole picture. Different medications can kill cartilage. And so those are all preventative, but I don't think we actually know why arthritis forms in some people and it doesn't form in others. So until we have a good answer for that, I don't think we can really do anything to prevent it besides healthy lifestyle, avoiding things that are going to do damage to the cartilage. They are working on drugs to try and increase cartilage and prevent arthritis from progressing, but those drugs are in early stages of clinical trials, and they really haven't even done animal testing on them yet. So we are a long way off from that. Still waiting to get on a knee replacement list where I'm hoping soon. You must be from like Canada or another country, because in America it is not hard to get on a knee replacement list. That's one of the big things. A lot of people get put on this list in places where there's hey, what's up from the Philippines? A lot of people get placed on a list if they're in like a socialized medicine country, and it could be like a year to 2 years waiting for a knee replacement. Which can be pretty debilitating. That piled up during the pandemic and was a big issue. Any solution for numbness after surgery? Give it time, it may come back. If it's still there at a year, there's different desensitizations procedures that you can do, but it depends what was affected, what nerve. A year and a half wait from Canada. So, I wish it wasn't like that. I'm sorry. For me, I'm a busy surgeon. I do a lot of cases, but I can do a good number of cases in a day. So the wait isn't that terrible. Maybe you're waiting anywhere from 4 to 8 weeks for surgery here, but usually it's not much more than that, and sometimes even less. Have you ever performed a tibial tubercle osteotomy? Yes, I have. Bone graft on my right hip, and I still can't feel it. Did they do that for avascular necrosis? That would be the most common reason they would do that. Or a previous fracture. Yes, I've done tibial tubercle osteotomies. Usually you do that for patella tracking issues. Conformis is a market. the thing about conformists, so you get a CT scan of the knee, you get custom jigs printed. There's no data to say it's better. The implant's much more expensive, and sometimes with the custom jigs, I've had issues, so I don't actually use conformists. What's next after knee reconstruction fails due to injury at work? I had both knees in an immobilizer, waiting to get looked at. There's things that can be done. You can do revisions, you can fix what's wrong, you can get different scans to see what's going on. So there are options. So you can replace the knee, then you can revise the knee, then you can re-revise the knee, then you can replace the distal femur, which is the end of the femur bone. Then you can replace the proximal tibia, then you can replace the whole entire femur bone. And so there's a lot we can do. Obviously we want to minimize surgeries, but those are all things you can do. Just had an ankle ORF. Hope you heal up well. Hopefully it wasn't that bad, and they get you back on your feet. What is the cost to the patient for the knee replacement surgery at my hospital? It's covered by insurance, so it's whatever their deductible or copay is. I operate on insured patients, so if you're Medicare, which is everything's usually pretty much covered with that. Grafts are very strong. What's up from Oklahoma? How's it going? Do you have a weight cap before doing surgery? So I like BMI to be under 40. BMI is a combined measure of your height and weight. It's not a hard cutoff. You were born without meniscus. That's an interesting one. I've heard of discoid meniscus, but completely no meniscus, then your knees probably hurt really bad. Maybe it's discoid. Discoid meniscus would be more common than no meniscus, but if you have no meniscus, then you probably have really bad arthritis, which is bad. Toenail fungus? I leave toenail fungus to the podiatrist. Sorry, I wish I could help you with that one. Probably clean up the toenail, maybe remove it completely. I've seen that before, and some antifungals. Do I use a robot? I've used robots before. There's issues with time of surgery, CT scans, extra pins in the bone. I'm not a fan of the robots. Yeah, you could go ask a podiatrist about some toe fungus. Unfortunately, that's not my specialty. I have sticker syndrome. I will have to look that one up. I think I've heard of that before, but I'm not familiar. It sounds like a more rare type of syndrome. There are some very rare syndromes in patients that I treat, but if meniscal agenesis is something with that, hopefully your knees aren't too bad. I've seen some patients who have these super rare syndromes, and there's only 10 cases in the entire United States, and it's they just happen to come in and see me. So there's so many syndromes with names. They have different manifestations. There's different levels of those syndromes. Knee replacements do really well. The implants that I'm putting in are by 25-30 years, about 60% of knee replacement implants are still intact. So the goal is to give you an implant that could last your lifetime. Euflexa is a gel injection. I give it to patients when they're trying to buy some time before having a knee replacement. What do I value most in a sales rep? Reliability, knowledge, and being able to make the situation efficient and make things move. Being able to, for my knee replacements, being able to tell the tech what the next steps are and getting everything ready. I did my residency in New York and at SUNY Downstate, and I did my fellowship at University of Virginia. If hip and knee wasn't an option, what fellowship would I have picked? Oh man, maybe sports medicine. Tired of canceling patients with an elevated A1C. Let's talk so those patients can have the needed surgery. That's A1C is a hard cutoff. It is an A1C higher than 8. Your risk of infection is incredibly high. So patients should not get joint replacement surgery if their A1C is more than 8. They can modify that. That is a modifiable risk factor that will significantly improve the risk of not developing an infection and having a good outcome. So, SUNY Downstate, Dr. Urban, yeah. He was the chairman. I believe he's still the chairman. What's the role of the PA in the OR? PAs help you retract, help you get ready for the procedure, help you suture up at the end. So PAs can do a lot and they can be very helpful. They help just get everything ready, talk to the patients, round on patients, check the chart preoperatively, make sure nothing's missed ahead of time. So that's a good PA or physician associate, as we're calling them now. What implants do you use? I use mostly DonJoy for my primary hips and knees. Sometimes I'll use Stryker, sometimes I use DePuy. It depends on the patient. Do most patients with an ACL injury end up needing a total knee? I would say a good number do, and there's some that don't. I would probably say it's probably about a 50-50 bet if you need it or not. It depends how well not all ACLs injuries are the same. Some can have meniscal tears, some can have cartilage damage, all that can make it worse. Some can have fractures. So not every ACL is the same. I work in Washington, D.C. and Maryland. No love for Zimmer. I've used the Persona knee. I use Zimmer for my patellofemoral replacements. I don't know. Number one safety precautions you wish patients will do or help themselves with. So before any joint replacement surgery, I have patients wash themselves at home with something called Hibiclens. I have them put mupirocin in the nose, which most people have staphylococcus in their nose. It helps to kill it and prevent infection. So just stay clean before your operation, clean up, do the appropriate preoperative steps, and all that's helpful. Get an ice machine if you're gonna have a knee replacement. Have I seen compartment syndrome in a post-op patient? No, I've never had compartment syndrome in one of my post-op joint replacement patients. I have treated compartment syndrome, meaning patient came into the hospital with a trauma and their leg was crushed and I had to release their compartments, or a garbage worker got their hand smashed in a dumpster and I had to release their compartments, but never compartment syndrome after a knee replacement. I would say compartment syndrome after a knee replacement is probably due to an arterial type of injury, which is very rare. Yeah, ice machine for my shoulder. It was my lifesaver. I don't understand the people on here who say that ice delays healing. Ice is great. It is an anesthetic. It decreases inflammation. People post-operatively do a very good job with it. Funny or scary surgeries while performing an operation. I've seen mostly everything, so there's nothing that can really happen that I'm not prepared for. So there's nothing scary. If I'm worried in an operating room, that is not a good thing. I'm prepared for everything up to the most catastrophic events. They don't happen that often, but I am prepared if they do. Have you seen malignant hypothermia? I do my surgeries under spinal anesthesia. Malignant hypothermia is from general anesthesia, so I have never actually seen it. I've heard stories about it, and usually they're prepared, anesthesia is prepared for that, but all my cases are under spinal, so malignant hypothermia is not really a thing with my hip and knee replacement patients. Thanks for all the support. I really appreciate the follows, the double taps, the likes. Thanks for supporting the channel. It means a lot. Almost all my bones crack when I move, and sometimes I crack my bones so they're not so stiff. That's fine. There's studies that show cracking bones does not cause arthritis. You're safe. Yeah, I'm on both right now. How long does it take to become an orthopedic surgeon? It takes 14 years. It takes, I just posted, it takes 14 years. It's 4 years of college, 4 years of medical school, 5 years of residency, 1 year of fellowship, and then you're an orthopedic surgeon. PTs do a great job with my patients. Get up and walking, and walk quicker, and that's the goal. And so all my patients get PT. No, I do some upper extremity trauma. Yeah, I'm answering questions from a couple different chats right now, so they're all good talking points. Hey, what's up, Ortho RN? Thanks for taking care of all the orthopedic patients. You probably are not appreciated enough, but we are appreciative. 2 TKRs, so you've had a revision. and it still makes noise. Sorry to hear that. I would see if there's any therapy you could do. Sometimes you can do blocks. It depends what it was done for. What type of surgery do orthopedic surgeons do? Great question. So orthopedic surgeons treat the musculoskeletal system, meaning any bone, tendon, injury, we will treat. Now you can expand that more, meaning like some surgeons will do skin stuff and flaps, like some hand surgeons will do plastic surgery type stuff, but mostly musculoskeletal, some skin. Where are you building your new home? I'm building my home in Bethesda, Maryland. We are tearing down a house and waiting for the permits to build the new one. So, yeah, that's a big thing. Thanks for the question. Stem cells to help knees. Stem cells are very expensive. They may not always provide as much relief as you want. Cortisone is shown to be better. Gel injections are gel injections work well. PRP stem cells are expensive. How long have I been in Washington, D.C.? Oh, we're running a little low on battery. How long have I been in Washington, D.C.? I've been in Washington, D.C. for about 2.5 years. What's the hardest part of my job? I enjoy my job. Probably long clinic days, like seeing 50, 60 patients in clinic. That is a really long day. So sometimes it gets hard at the end, but you're just trying to help as much as you can. Has anyone told you robots are going to replace surgeons? I did a video on that not too long ago. I just put a new video up on the YouTube channel if you want to check that out. But yeah, I just did a video on that, and I think the surgeons will have to control the robots. No matter what, you'll still need it. Congrats on the new house. Thank you. There's a work in progress. It is hopefully going to be very nice. Is it bad to ingest 3,000 milligrams of the Tic Tac Toe one killed me. Yeah, I mean, that was funny. I like that. I like to make medical content that's enjoyable. I appreciate that comment. How bad is reconstruction of a failed TKA? TKAs are intact 25, 30 years, and about 40% will fail by that time. So it's something that sometimes needs to be done. That's a revision surgery. It's common. It happens. It's not that bad. Do I like my job? I love my job. I love fixing people. I love helping people walk again. Any tips you would give to someone to get into American Residency from Canada? Get a lot of research, maybe do a year off and do a research year. That can be helpful. Any experience using the Mako? Mako's a robot. It takes a little more time. Yes, I've used it before. You have to put pins in. And sorry if I missed your question. They disappear really quick. But you put the pins in. You may need a longer incision. You may need extra pinholes. So I don't use the Mako for my routine cases. I will use like robotics or navigation for really difficult deformity cases. I don't think I'd like a robot operating on me. Yeah. Bursitis in both shoulders. Cortisone injections can help. Sorry, I'm not a plastic surgeon. I can't help you with your nose job questions. What specialties did you want to do besides ortho? I was at ortho. I would have applied to other ones. I'm going to get you on Rosa. Rosa just moves the jig. There's so many other things that do that. So Rosa's another robot out there. My knees pop every time I bend. The popping is from infolding of your joint capsule. It can get hyperplasia, which means it just gets a little thicker there. And that can cause popping. So not uncommon to have popping with your knees. Hi, doctor. I have a question. A fracture of your finger to stop hurting? Maybe get an x-ray. Check it out. See if it's broken. See if anything's out of place. Let's see. Do you think proper running shoes helps for people who are walking? Well, yes. I think anytime you can wear sneakers or a good insole, that's going to help support you. Especially if you have like flat foot or anything like that. Oh, with the Da Vinci, they did surgery on a grape. Yes, they did. Da Vinci robot is not used in orthopedics at all. Have I seen diabetic amputations? Yes, I have performed diabetic amputations. When I worked at a level 1 trauma center in a previous lifetime, I performed amputations. I've done toe amputations. I've done midfoot amputations. I've done ankle disarticulations, which means taking the joint apart, below the knee amputations. I've done above knee amputations, and I've done hip disarticulations, which means taking the hip apart. My favorite surgery to perform, I really like hip and knee replacements. I love them. Patients have good results. They tend to get up and walk, so that part's great. Post-op pain management, yes. So I give 4 medications are my main medications. I give Tylenol and Celebrex, and those are non-narcotic medications. The narcotic medications are Tramadol and oxycodone. So the way you do it, you take Tylenol, Celebrex post-op, you take Tramadol if you have moderate pain. If it still gets worse, you double up on the Celebrex, double up on the Tramadol, and then if it's really bad, you take the oxycodone. Many people don't always need oxycodone after their operation, but you have it on hand if you need it. Have you seen anyone squeamish that wanted to be a surgeon? Okay, give me a second. How do I feel about PRP? PRP is expensive. And the results are questionable. So I usually tell patients, try cortisone first. If that doesn't work, you can try gel. If you have PRP injections can cost $1,000 to $2,000 for an injection. So, if you really don't want a surgery and you have that money to blow, whatever, okay, try it, not a big deal. Stem cells can cost $5,000, and the results, they tested injecting PRP and stem cells and compared it to saline, and there wasn't a big difference. So, if you have money to blow, sure, you could try it. I don't usually recommend it. What's the youngest for a patient for total hip? I've done a 18-year-old patient who flew over, I was working in New York, they flew over from Africa. You're required to treat people, especially if they're in a lot of discomfort and can't walk and things like that. So I gave them a total hip replacement. They did very well. So 18 years old. The reason they needed a hip replacement so young was they had an infected hip, a septic hip as a child. You got to have pretty steady hands to be a surgeon. So I disagree with that statement. I have seen old surgeons who have very shaky hands with who are still really phenomenal surgeons. And the way you do that is, so if this is the table or anything like that, you brace your arm on something. The further you brace your arm, the less shaky your hand is. Like way out here, your hand's like all shaky, normally. But if you just brace it on something, like I'm young, I haven't developed dementia or Alzheimer's or any musculoskeletal or neuromuscular problems. So, my hand's pretty steady. But even if your hand's not steady, just put it on something and then you could do whatever you want and it's really steady. So, that goes back to physics and torque and everything, but decrease the distance of the lever arm and so it's okay. Hey doc, at work started using Zin Relief. What are your thoughts instead of Exparel? It's a newer drug. I know they've been pushing it a lot. I think it's a weird application. It's like a topical application, which I inject Exparel. Topical application doesn't make a lot of sense to me, but they're trying to replace Exparel for cost and things like that. We'll see. Exparel's expensive. It's really expensive. Thanks for all the follows. Thanks for all the likes. I really appreciate it. Thanks for keeping my channel running. And I love these interactive videos. I'm going to try and do another live down the road, but you guys have been great. And if I didn't answer your question, sometimes, put a question or a comment on the video. Sometimes I'll get to it and answer it. But I appreciate you guys. This has been great. I'm going to bounce for tonight, but thanks for joining.